Hold on. Good morning, good afternoon, good evening, depending on where you are. And I'm going to talk to you about phalangeal neck fractures, which I think have gone through a lot of changes in how we think about them over the last 10 years. So to start with, phalangeal neck fractures are actually fairly common. They're 13% of all pediatric fractures, which seems like a very high number considering what they are. Most commonly from the hinge side of a door. Child sticks their hand inside a door. My son's done this, not this fracture, but tried to remove his entire hand by putting his hand inside the hinge side of a door. The distal fragment may appear small in younger children because it can be mostly unossified. And so the fragment's actually larger than it appears most of the time. There is a classification, as there is for all fractures. Here's the Alcaton classification, which basically is 1 is non-displaced, 2 is dorsally displaced, and then the 3s are displaced in unusual and fanciful ways. So why do we care about phalangeal neck fractures? Well, most of these fractures in my practice present late with callus formation already because they're mostly ignored by the parents because the child does not seem to be that symptomatic. Rotational deformities are a problem because they can cause scissoring, and that sometimes is what brings in the kids. They have coronal plane deformities on occasion that may have cosmetic and functional issues. And the other problem is loss of the subcondylar recess that can cause loss of terminal flexion. And that loss of subcondylar recess looks like this. I took this from Dr. Tada's paper from Kanazawa, which is one of my favorite places in the world if you ever get a chance to visit. So we've been told, and this is sort of the fracture later on, and you can see that some remodeling has occurred, right? And we've been told that remodeling only occurs close to a physis. That's not really true, because there really are two kinds of remodeling. And this is from a paper that Scott and I did last year for Sanj Kakar in the clinics of sports medicine. And it shows the two different kinds of remodeling. One is dependent on the physis, which is A, and the other one, which is B, which is dependent on the physis. So A is sort of this periosteal remodeling, and B is really physeal remodeling. And you can see from Tada's, I'm not advancing, hold on one second. Okay. So you can see from this X-ray that the remodeling is really periosteal remodeling. And that can happen away from a physis. So previously we thought, you know, in all the literature in pediatric orthopedics is you have to be close to a physis to remodel. It has to be in the plane of motion, etc. Not really true. Periosteum can also remodel, as in a clavicle. We all know the clavicles remodel quite well, and I'm not really sure where the growth plate is. So there you go. This is from Roger Cornwall, a very simple treatment algorithm that all ends in placing pins if you look for type 2s and 3 fractures. This, as of 2014, was pretty much state of the art. And we would pin pretty much all of these. And surgical treatment certainly has some benefits over non-operative treatment. A timely closed reduction and cross pinning may be the best treatment for some fractures. Why? Because there's no waiting for remodeling to occur. There's less need for follow-up because there's less risk of loss of reduction, and there's less risk of terminal flexion loss. And it allows for correction of coronal and rotational deformities. Impending malunions can also be treated with intrafocal pin osteoclasis, as has been shown to us by Peter Waters and Don Bay, and then the osteotomy of late presenting fractures with great care to preserve vascularity. There's a high risk of AVN with any open treatment. And I would suggest to you that this is only for rotational or coronal deformities that are symptomatic. So let's talk about surgical techniques. This is your classic technique published only recently on the cross pinning of phalangeal neck fractures. looks something like this. You use the collateral ligaments to basically pull down the fracture and to reduce the fracture. And while you're holding the joint flexed, you drive in your pins. There's this whole strategy of making sure that on the lateral, you're just at the tip of the bone, which, as I said earlier, may not represent the actual tip of the bone because there's some bone that is not yet ossified. And it looks something like this. And they suggest these tiny little 3-5 pins in this cross fashion, which I can tell you is a fairly difficult operation to do. And if you've tried to do this, it is not that it's impossible, it's just futzy. Then came this article by Rob Strauch, which was Journal of Pediatric Orthopedics in 2012, and 2012 being a banner year for the phalangeal neck fracture. And he had this great idea where you bend it down and then you drive it retrograde, allow it to come out the other side, and then drive it antegrade and have it come out the end. Interestingly, also from New York, Nader Paxima published the same technique the same year in a different journal as a technique paper rather than an actual paper. So I don't know who the winner is here and who came up with the original idea, but I'll let them fight it out because they're both from New York, one from Midtown and the other one from Northwest. And so what Scott Kozin says is big pins for big people and big pins for little people. He also likes little dogs, as you can see from there. So when you, we don't like these little tiny 3-5 pins. We use 4-5 pins because they're just stronger. And we have not had any issues with physeal arrest from these pins. And then interestingly, on the same year, after getting personal communication with Strauch, we published this technique, which claiming him as the originator of the idea. And it's basically the same thing. Again, you go follow A, B, C, D, E, F, and you have at C, you have you enter in a retrograde fashion out the back, and then extend the finger, and then go antegrade. And this technique is so much simpler than the cross technique and really requires only one pin. Now, if you have a rotational deformity, obviously you're going to need a second pin to fix the rotational deformity. I don't think I've ever had to put in a second pin. Sorry. And here's the classic paper of what do you do if they present late. So the percutaneous reduction of the incipient malunion, and that is the osteoclasis. And he recommends using a K-wire rather than opening the fracture to be able to lever this or Kapanji the fracture into a good reduction and then pinning it. We don't pin it with a cross pin, we just do the same Strauch technique, and I'll show you that in a second. Here's another schematic of how you do that, and I'm going to show you a video, which hopefully will play. There's our phalangeal neck fracture. You can see a slight coronal deformity. Here I am performing the osteoclasis and then the reduction. And you can see now we have an anatomic reduction. The pin is placed retrograde. We confirm to make sure it's in the right starting point. And you can see I'm using a semi-sterile technique. The pin comes out the back. You can do this by yourself, but it's always easier to have a helper, in this case, our fellow. And then you extend it, check the x-ray again, and you can see that you have a nice reduction. And you drive the pin forward, out the front of the finger, out the distal end of the finger. And I'm going to forward a little bit in the interest of time. There's your reduction, and there's that. All right. So that's easy enough, right? You see these, you pin them because they don't remodel because there's no physis there, and we kind of know that that's really not true anymore. So here's an early study, 2016, comparison between buddy taping with a short arm splint and operative treatment of displaced phalangeal neck fractures in children. Well, look at this, 37 patients under 12 years of age, right? And here's what they look like. And you can see in A, B, and C that the fracture was not well reduced, but over time remodeled. And I'd be hard pressed to tell you that that picture in C was ever fractured. And the result was full range of motion. Well, when you look at their actual data, you can see that some of the patients in group 1 that had the buddy taping and casting had a rotational deformity or coronal malunion, as well as some loss of flexion. Whereas then the group 2, which had a pinning, one of them had an infection. There was some extensor lag in 2 cases, but otherwise they did really well. So I think it's a bit of pick your poison in terms of what do you think is best for your patient based on this study. This is the longest follow-up that I could find looking at patients with phalangeal neck fractures. And I think this was sort of the big study by our fellow Ben Puckett and Waldo Floyd, Glenn Gaston, Alan Pelkovich, Gary Laurie. These are all names we know. And if you look at their patients, they had 8 patients with a wide range of injuries. And here's the months of follow-up. And you can see they had fairly long-term follow-up in most of these patients. They looked at a subjective questionnaire as well as the objective translational deformity. And it's really interesting. Look at this final sagittal plane deformity, dorsal angulation, 0 degrees. So complete remodeling. As Chesko would say, 0%. And here it is, 0% final translational deformity, despite having some of these at 100% translational deformity. You can see even the older child who was 14, who had a 40% translation, still remodeled fully. And their ranges of motion were quite good. Interesting, 2 of those patients complained of cosmetic deformities, even though by their data, they did not have a very bad deformity in terms of coronal plane. So there must have been some rotational deformity that was missed. Again, there it is. So take-home points from this study are the translational and sagittal plane angulation deformities completely remodel, even in kids as old as 14, if you're willing to wait long enough. But there's minimal remodeling in the coronal plane, and no long-term rotational deformities were seen in this limited series. Although, again, I caution you that may be a miss, because they showed some patients still complained of deformity. It's unclear why some patients, again, complained. Here's another study, 2021, from our friend Schulman. A comparison of casting versus splinting for non-operative treatment of pediatric phalangeal neck fractures. Now they went from 8 patients to 47 patients. So this is a much bigger study. And this just assumes that they're going to remodel, because they treat their patients with either casting or splinting, even for displaced fractures. And you can see from their data that there's basically no difference, whether or not they splinted or they casted, in terms of post-reduction changes in coronal angulation, translation, sagittal translation, or angulation. So take-home points. Only fractures without coronal or rotational deformities were treated in these splints or in casting in this study. Again, if there's rotational or coronal deformity, you have to pin these. Otherwise, as I said, they underwent pinning. And in terms of whether you splint, cast, or from the other study, whether you do buddy taping and a cast, it doesn't really matter. They all seem to do well, partly because of the tremendous remodeling potential. That is not physeal remodeling, it is periosteal remodeling. But I caution you that not everything is great in the state of Denmark here. The malunion of fractures of the proximal phalanx in children. Here's another paper. Here's the paper from Kanazawa that I mentioned by Tada. And you can see that some of those patients did not remodel, and they required a subcondylar recession. So removing bone from the area that had not yet been removed in order to allow these patients to have full flexion. So that always remains a concern for these severely translated fractures, particularly in older patients, that they will not be able to fully remodel, right? So where does that leave us, right? So we know that they remodel a lot. We know that they don't remodel rotational deformities. We know that they don't remodel coronal deformities. We know that they remodel sagittal deformities quite well, but even when they remodel, they still have a spike in the subcondylar recess, which means it blocks flexion. So my recommendation, based on looking at all this data and what we do in our practice, is we reduce and pin any rotational coronal deformity fractures. We use a simple Strouch or nadir pexima, or maybe we'll call it the New York technique for acute injuries. We still perform an osteoclasis for subacute injuries if they have these coronal or rotational deformities, or if they're in older kids, and wait to do late osteotomy for late presenting fractures if there's insufficient remodeling. So what does that mean? We generally will wait. If the fracture does not move at all and we can't do an osteoclasis, we'll abandon the procedure at that point. It may be best to treat older kids with acute injuries with closed reduction of percutaneous pinning, even for just sagittal plane deformities. And again, the simple Strouch technique, the osteoclasis, and for late presenting fractures, if it's just a sagittal plane deformity, you can do a subcondylar recession, and like Tata suggested, to be able to get full motion. However, younger kids may be fine with just a splint if they're stable in the coronal plane and they're not malrotated. And happy first birthday to the PULM and to Chesko for having this great idea. And thank you very much. And I look forward to Erna's comments.
Thank you, Dan. So in France, they call this technique backward and forward technique, the Strouch technique. See. So
not the New York technique.
I don't know.
It's the cha-cha.
So now, okay. So now Dr. Nietosvaara will moderate the talk. Please.
Okay, Dan, thank you for an excellent presentation, which combined your own experience with all that is written about this topic. A few comments. You didn't really talk about us, the surgeons, because in my opinion, fingers in children are very small, and especially in like teaching hospitals, it is quite often the registrar that is treating these, or even in other hospitals, someone who doesn't have a lot of experience. So in my opinion, it makes a great difference who is treating the child, especially if you're trying to pin them. It's actually very difficult. And in some hospitals, the image intensifiers are not good enough to really see what you're doing. So I've seen quite many completely wrongly pinned patients. There's nothing's been going on. So I sometimes advocate younger colleagues, especially if they don't have a lot of experience, to actually open these fractures to see what they're doing, because I don't think there is a lot of room for several pinning attempts. The video you showed how an experienced and excellent surgeon can do it well. And then I also agree with you that this is like all pediatric fracture treatment. Many kids, they would do fine without us. They would remodel, but not all. The difficult thing is to know which one need an operation. And then the last comment on this study, you showed pictures A, B, and C. In my opinion, if you look closely to picture C, the middle phalanx is actually, it has become shortened. I've seen a couple of patients like that, and I strongly suspect that in some of these kids, the distal fractured fragment completely resorbs away. Then you have some sort of a neo joint there. But the middle phalanx doesn't have a normal joint surface anymore. And the final comment that these fractures where you have the middle phalangeal joint surface facing backwards, proximal or dorsal or volar, I think they should be treated surgically. But the problem again is that it's sometimes very difficult to make the diagnosis. So maybe could you comment on the experience of the surgeon who is treating this? Does it make a difference on what the surgeon should do? And what do you think about this possible resorption of the distal fragment if it's completely off? Maybe you could comment on those things.
All right, that's a lot. That's a lot. So yes, we at Shriners get these fractures referred into us from some very experienced local hand surgeons who are quite good. They don't feel comfortable treating these because of exactly what you said. Part of the difficulty, I think, with these fractures is doing this cross-pinning technique that has been described. I find that technique to be incredibly difficult to pull off. You have to hold the reduction, put the pin in. I think it's really difficult. I think the Strouch technique allows, I've taught this technique to our fellows, and I think with a decent fluoroscopy, it's actually a pretty easy technique as long as you follow what I showed in the video. You flex the finger down, you take a good lateral and a good AP to make sure your starting point is appropriate. And once you have a good starting point and your angulation is okay, it's actually a pretty easy thing. So I think that as long as nobody knows the secret locally of how we do this pinning using the New York or the backwards forwards, the cha-cha Chesco technique, right? Then as long as nobody figures out our secret, they'll keep referring us these patients and we'll keep fixing them. But I think if you're trying to do it the traditional way, very, very difficult to do. And I would suggest that I'm not sure opening it is the right answer. But I think to your point about these rotated fragments, I'm not sure how you even diagnose that in a young child. I think your point is correct. If they're flipped, and I've seen those, but they're really rare. But I'm not sure that I can diagnose those right off the bat.
How many have you seen? Because I have seen less than 5.
2.
Yeah.
2. That's not a lot. So again, to your point, what?
It always feels great when you make the right diagnosis and open it up and you can get it back in place. And I completely agree with you that the cross-spinning technique, especially percutaneously,
very difficult. It's
really difficult. I mean, I agree completely with you, and I'm a little bit astonished why people are afraid of pinning through the joints, because that is much easier because you're in the middle of the bone. It will kind of go through the fragment, and it doesn't bother me either to go through the joint or joints once.
Yeah, I mean, we use 4-5 pins, or what is 4-5 pin in metric? It's like a 1.3 or 1.5, something like that.
We have like 0.8, 1 millimeter, and 1.25.
Yeah, I think we use bigger than that. We use fairly big pins. As Scott says, big pins for big people and big pins for little people. We have never had a physeal issue with a 4-5 pin, or I think a 4-5 is like a 1.45. I think that's.
I think it's 1.25 probably.
Well, we can differ over 0.02.
Well, next time we meet, we bring our pins and we can compare them.
We will duel. So yeah, I've never had a problem with the physis, so I agree. I don't have an issue. The same thing with olecranon fractures or Montasia fractures. I'm more than happy to put a 2-0 pin through the apophysis and the olecranon. I think these smooth pins do very well. I am more reluctant to do that in the distal radius because I have seen those develop growth arrest, but I've never seen in a finger.
Well, I don't think you can cause a growth arrest if you drill once through any phases. But I think the problem is that if you do it like 15 times or 50 times, I've seen someone do, then obviously you end up in problems easier.
Right. Right. But I think the nice thing about this Strauch technique or the New York technique is that it's a long way between your starting point and the physis. And so you're in the right place before you get to the physis. So you can change your trajectory fairly easily. And yeah, and I think it's a much easier technique. So that's and by the way, you're probably right that there are probably more of these rotated weird fractures than we're aware of, and those are probably the ones that go on to AVN.
But
right?
Does it matter? Because I mean, usually the function anyways is quite good, at least in the short term.
Yeah, I don't know how they do as adults.
Yeah, I don't know either.
Yeah.
And I also enjoyed you showing the remodeling, the two different pathways of remodeling. I completely agree with you, and I think the same happens with distal radius fractures that are left in an overriding position. They remodel because of this periosteal remodeling, and if you leave them in a quite moderate, or even there is none. So you don't even have to rely on physical remodeling.
Yeah. So I agree. Yeah. Andres agrees as well.
Yeah, that's too bad. We agree too much.
I know. I think we're supposed to fight. We'll fight over K-wires. They're more dangerous.
Yeah. Okay. Do you have like because then you can go back and forth. I don't like cut the end because then it's not the point is not in the middle, and I believe you do more damage.
That's correct. So we have double-ended. We use double-ended K-wires for sure.
Excellent. Good for American kids.
Good for American kids. We have great. I mean, yeah. And then there were some other points that you made which I can't remember.
Oh, probably not so important.
No, they were good. I just can't. I can't remember to comment.
What was that? Yeah, well, I was commenting on the fluoroscopy machine that, I mean, in some places they have large ones, and if you try to visualize there's a small child's finger there, it's impossible.
I think we have to go.
Yes, no, there is a trick for the large fluoroscopy. There is a trick. So you have to lean the finger over, not over the receptor, but over the emitter. Yes. Then you, even if you have an old and big one, you have a better image. But you will not be able to pin in a cross way, even if you are an expert. That's why the forward and backward technique is just genial. So I think that technique can be applied for someone who is not really an expert. I think.
I also believe that if you pin it through the joint, it's much more atraumatic than trying to pin it from the sides. And then you're going 2 times through the joint and maybe even causing more damage to everything. It's not very stable.
Yeah, and from an infection standpoint, if anything, you'll get an infection at the tip of the finger rather than in the joint, because you have a long way to get there, right?
Do you guys have like Mother's Day? Because we have a Mother's Day here in Finland.
It's Mother's Day today. I'm cooking.
Because I have to start cooking to my mother very soon.
You all right? Very nice.
Oh, thank you very much. Thank you. A really worthy talk. So we can move to the next one.